All right, let's kick off some nephrology and genitourinary for the emergency medicine shelf. So I'm super excited. This is a good topic and it's pretty straightforward. So, acute kidney injury, or AKI, it's defined as an increased creatinine greater than 0.3 milligrams per deciliter, or, and that's within 48 hours, creatinine greater than 1.5 times the baseline within 7 days, or urine output less than 0.5 milliliters per kg per hour. The three big categories you want to look for acute renal failure are pre-renal, intrinsic, and post-renal. Pre-renal, you want to think about hypovolemia and hypotension, things that cause a reduction in renal perfusion. It's often cardiogenic in nature. Fluids is going to resolve the cardiogenic causes of renal failure because it ultimately restores the circulating volume. That makes sense. Intrinsic, you want to think about acute tubular necrosis, vascular in origin like dissection, thrombosis, embolism, glomerular in origin like RPGN, interstitial disease. And then lastly, post-renal is often due to obstruction. The most common cause is BPH. Urine studies included here, such as fractional excretion of sodium, as you can see is one of the parameters in the table on the left. That helps determine if the origin of the AKI is pre-renal, intrinsic, or post-renal in origin. So let's say you've gotten the urinalysis back and it's time to interpret your results. Above in this table, you can see that red blood cell casts are an indication for glomerular disease. You want to think of RPGN. Eosinophils, think about interstitium and interstitial nephritis. Muddy brown granular casts, think about the damage localized to the tubules, and you'll see that in acute tubular necrosis. Nephrotic syndrome, that's greater than 3 grams of proteinuria a day, whereas nephritic syndrome is recognized by microscopic hematuria. Both have edema and variable presentations. So correlating with the table, red blood cell casts, think nephritic syndrome, and the two big ones are rapidly progressive glomerular nephritis, or RPGN, and post-streptococcal glomerulonephritis. RPGN is autoimmune, and there are autoimmune antibodies present in the glomeruli. There's going to be crescent formation in the glomeruli, and if it's untreated, it can lead to end-stage renal disease, so you just want to go ahead and start steroids in these patients. In post-streptococcal glomerulonephritis, the treatment is mostly self-limited. Antibiotics do not prevent the manifestation of glomerular disease. If you see eosinophils on urinalysis, you should be thinking about acute interstitial nephritis. It's immune-mediated, often caused by medications such as penicillin, sulfas, quinolones, diuretics, NSAIDs, infections, autoimmune or immune etiologies, and then, of course, neoplasm as well. It's going to be present 3 to 5 days after drug exposure, but can be delayed up to 18 months as well. Diagnosed via renal biopsy, and the treatment is just discontinue the offending agent or treat the underlying etiology, whether it be infection or cancer. Muddy brown granular casts are seen in acute tubular necrosis, and it's a result of prolonged renal ischemia that does not necessarily respond to intravascular fluids, which is just one way that you can distinguish it from the pre-renal pathology. Rhabdomyolysis is muscle necrosis with release of various byproducts. The results from trauma, crush injuries, infection, burns, heat stroke. Heck, you can even see it in COVID. The most common infectious etiologies are Legionella and influenza. And then myoglobinuria, that's when you have a positive heme dip on urine without red blood cells on the microscopic examination. So myoglobinuria, it could be present in rhabdo patients. The CPK levels are greater than 5 times the upper limit of normal, and abnormal lab values include hyperkalemia, hyperphosphatemia, and hypocalcemia. The treatment is IV fluids with the goal of urine output of 3 milliliters per kg per hour. And now that we've familiarized ourselves with the BU and creatinine ratios and creatinine in general, there is another parameter to look at to determine if someone is at risk for contrast-induced nephropathy, and that's the GFR. If it's less than 60, they're going to be at risk of contrast-induced nephropathy. Diabetes, elderly folks, and those with hypertension are at risk. Treatment is to give fluids before and after the study. And remember, you want to hold that metformin 48 hours prior to the study in diabetic patients. Indications for emergent dialysis, I want you to think of the AEIOU mnemonic. Acidosis, that includes refractory or pH less than 6.9. Electrolyte electrolyte abnormalities, ingestions, which include iron, isoniazid, salicylates, theophylline, methanol, barbiturates, lithium, ethanol, ethylene glycol, and depakote. The O stands for overload state, and U stands for uremia. Polycystic kidney disease is an autosomal dominant inherited disorder that can lead to irreversible renal failure. You diagnose with CT scan, which will show enlarged kidneys with lots and lots of cysts. Renal function will decline in the fourth decade of life, and most patients will pass away from cardiac causes. There's no specific treatment to blunt or attenuate the progression of the disease. Most will have coexisting hypertension, so you want to start these patients on ACE inhibitors. Peritoneal dialysis is a form of dialysis that patients do not require heparin for, just to keep their line open, and there's fewer complications. The most common complication, however, is peritonitis, and to diagnose this, the patient will present with abdominal pain and fever. Peritoneal fluid analysis will show white blood cells greater than 100,000 with PMNs. The treatment is intraperitoneal antibiotics, and if they're septic, obviously you're going to switch to IV antibiotics. Acute cystitis is dysuria, increased frequency, urgency, hematuria. It's an infection of the bladder. You treat with fosfomycin, nitrofurantoin, and Bactrim. Acute pyelonephritis is an infection that involves the kidney, right? So you're going to see things like flank pain, cystitis, fever, vomiting, nausea. You want to get a urine culture in females less than 2 years of age who have fever without a source, regardless of urinalysis findings. Treat all pregnant women who have bacteria in their urine because they have a high risk of the bacteria ascending and affecting the kidneys. Treat all the women, even if they're asymptomatic and they have bacteria in their urine. The main cause of UTI in females is E. coli. The second most common is Staph saprophyticus. Prostatitis is inflammation and infection of the prostate. Men will complain of fever, chills, dysuria, and pelvic, perineal, and rectal pain. There can be pyuria present, but there's no blood in the urine. The prostate will be firm, edematous, and very tender. Men less than 35, the most common cause is gonorrhea and chlamydia. Men older than 35, the most common is E. coli. And the risk factors include multiple partners, unprotected sex, and BPH. The treatment extends to 6 weeks for antibiotics. Nephrolithiasis. So kidney stones, they're going to present with hematuria, or 80% of patients that have kidney stones present with hematuria. There's 4 kinds of stones to be aware of: calcium, struvite, uric acid, and cysteine. The most common is calcium stones. The treatment for these is increase your fluid intake. Flomax, which is tamsulosin, is an alpha blocker, so that's going to increase the flow. Thiazides can decrease urinary calcium excretion, so sometimes you'll see them as prevention. Struvite stones form staghorn calculi and are often associated with Proteus infection, which is commonly seen at elevated pH. Uric acid stones are radiolucent, so they will not show up on radiograph films. You can use allopurinol to reduce formation of uric acid stones. And lastly, those cysteine stones are the rarest of the bunch. They're seen with patients who have inborn errors of metabolism. The best test for a kidney stone is CT without contrast. That's going to be a test question, or I could see it easily being one. In terms of dietary recommendations for patients with calcium stones, it's good for them to have citric foods such as oranges and lemons because the citrate will bind the calcium in the urine and be excreted, preventing stone formation. Stones that are less than 5 millimeters have a 90% chance of passing spontaneously. Stones greater than 1 centimeter in size often require surgery or lithotripsy. A diagnosis you do not want to miss is Fournier's gangrene, and it'll present with scrotal, rectal, genital pain out of proportion to examination. It's often polymicrobial infection in nature. It's a surgical emergency, and the risk factors are diabetes, IV drug use, alcoholics, people who are immune suppressed. Pyelonephritis is usually when there's the glans penis and the foreskin is irritated and inflamed or infected. It's from poor personal hygiene, primarily in uncircumscribed men. The first test you should order is actually a finger stick glucose, and that's because you want to check for diabetes. The treatment is local care, soap and water, topical bacitration, Phimosis is the inability to retract foreskin. It can lead to urinary retention. The treatment, if there's retention, you want to dilate the ostium. Patients may need circumcision. Paraphimosis is retracted foreskin that cannot be brought back. This is an emergency as it can lead to necrosis. The treatment is ice, manual reduction, or incision. Fractured penis is often due to forceful sexual intercourse due to rupture of the tunica albuginea. Priapism is sustained erection that can lead to urinary retention and impotence, often seen in sickle cell disease, trauma patients, and medication side effects. There's two kinds of priapism, low flow and high flow, as you can see in this table. And this is going to be very high yield for you. The ischemic or low flow, also you may see it as veno-occlusive. The physical exam is fully rigid and painful. The ABG will be deoxygenated venous blood. The ultrasound will show decrease or absent flow, and the treatment is aspirate 5 cc's of blood and inject 1 cc of 100 micrograms of phenylephrine, and you can send that aspirated blood off to the lab if you need to double check the ABG, if it's venous or arterial or deoxygenated and oxygenated blood. The arterial or high flow, the physical exam, you're going to see it's less rigid but still very painful. The ABG will show oxygenated blood. The ultrasound will have normal flow, and the treatment is observation. The reason you don't inject phenylephrine is in the arterial high flow priapism is because you're going to cause severe hypertension if you do so. So in this case, the treatment for arterial high flow is just observe. The last minute high yield nephrology and genital urinary section, we're going to cover testicular torsion. It's an acute onset testicular pain, less than 12 hours in duration. It's accompanied with nausea and vomiting as its symptoms. The patient may have intermittent pain if the testicle is torsing and then detorsing. The bell clapper deformity is when the testicle lacks the normal attachment to the tunica vaginalis, leading to increased mobility. This may present as a horizontal lie. The most sensitive finding on physical exam is an absent cremasteric reflex. Stroking the inner thigh fails to alleviate the testicle, or elevate the testicle, An elevated testicle is the most specific finding. You want to consult urology immediately. You want to attempt manual detorsion, and that's going to be in the same motion and same manner of opening a book. Definitive treatment is bilateral orchidoplexy. Epididymitis is most frequently in adolescents, and their risk factors are sexual activity, exertion, direct trauma like bike riding, for example. If it's diagnosed in prepubertal boys, you want to think of anatomical and structural abnormalities. Sexual activity is a risk factor, especially for males less than 35. You want to think about infectious causes like chlamydia and gonorrhea. Males who participate in anal intercourse, think E. coli and Pseudomonas. Males that are older than 35, you want to think of bacteria secondary to enlarged prostate. So that's going to be Pseudomonas, and you're going to treat with fluoroquinolones. Children, you think of Mycoplasma pneumoniae or adenovirus. The symptoms are pain localized to the epididymis with normal cremasteric reflex, and you diagnose via just clinical observation. Orchitis is the inflammation of testicles, most often due to infection, and the most common viral causes are mumps, Coxsackie, and rubella. It can be caused by epididymitis, prostatitis, or other STDs, and the treatment is supportive plus or minus antibiotics. The most common cause of urinary retention is prostate enlargement, and normal post-residual void in adults is less than 50 milliliters. The first step in management is immediate placement of Foley catheter. Last but not least, renal transplant patients. So basically, renal transplants are the most common type of transplant. Once the patient has received another kidney, they are considered immunosuppressed because they're trying to accept that organ without their own body rejecting it. So they're going to be taking things like steroids, tacrolimus, cyclosporin, and other agents basically to attenuate that immune response. They're at highest risk of opportunistic infection during the 2nd through the 6th month status post-transplant. You always want to be cautious and think about cytomegalovirus. It can present with gastrointestinal symptoms, leukopenia, anemia, elevated liver enzymes, and renal transplant patients need leukocyte-depleted blood in the event that they need a blood transfusion. Steroids can accelerate osteoporosis and increase the risk of fractures. Any rise in creatinine should be worked up in renal transplant patients. And status post 1 week transplant is when acute occlusions may present, the patient's they're going to come in with oligouria and renal failure. You want to get an ultrasound to evaluate for clot, and that is for the nephrology and genital urinary for the ER shelf. So please leave any comments if you have questions, and thank you all so much for your time.